However, of course, top peoples are around in the rooms as well. Today in gynecology, we will have two defense, one and next to each other. So we will have two exams in the row. One of them is István László Baradács, who is more than welcome him to be here, and Anna Evelin Juhász. She also will give a presentation. And I am also very pleased, and it's an unbelievable honor for us that we can welcome Bart Fauser, member of Academy of Europea, which is the largest academy in Europe, having more than 5,000 members and 92 Nobel laureates. And he's joining us to act as a chair of the unit. He's a really well-versed, renewed reproductive endocrinologist, best known in his pioneering work on the ovarian physiology and stimulation and IVF. And if I told his name also in Barcelona last week that somebody is coming, everybody said that, wow, this committee is really a professional one. But of course, the committee is not only have one members, but we have really today 8 people in the committee. So I am also very happy to welcome our other international examiner from Bucharest, Romina Marina Sima. Thank you very much for coming over. So first, have a 2 applause for the 2 international ones to come and to act. But of course, we have also from Hungary, from Pécs Bálint Farkas, very welcome to be here and being with us. We also have from Semmelweis University, Dora Kocka-Balogh, who is here. Thank you for coming over. We have Tamás Marton from Semmelweis University. Welcome. Gábor Varga, who is most probably known by you because he's the Vice Director of Center for Translational Medicine. Thank you, Gábor. And of course, the committee is extended also with 2 experts in methodology and in biostatistics. So Victoria Barna as a methodologist and Réka Tóth as a biostatistical leader will also join us. And thank you very much indeed. And I just would like to say good luck for the candidates and thank you.
Dear committee, dear audience, let me introduce my PhD student, Anna Evelin Juhász. She was born in Gyöngyös, Hungary in 1998. She graduated from Berzenagy János High School and began her studies at the Semmelweis University, Faculty of Health Sciences, majoring in dietetics in 2015. During her university years, she volunteered at Bátortábor, where she gained valuable experiences in working with children and supporting people facing health challenges. She graduated in 2019. Right after the graduation, she has started working at the Albert Schweitzer Hospital in Hatvan as a dietitian. Alongside her professional work, she completed her master's degree in nutritional science. During this period, we have started our scientific collaboration within a TDK project in 2021, which was entitled as Evaluation of Plant-Based Meat Alternatives. In 2021, she began her PhD studies at the Center of Translational Medicine, where she has been working under my supervision ever since. From the first steps until the very last, she was very dedicated to her PhD work, and in 2022, she was awarded as the Student of the Month by the Center of Translational Medicine. Since 2023, she has also been working as assistant lecturer at the Department of Dietetics and Nutrition Sciences, contributing both to teaching and research activities. Anna is very easy to work with, so I am grateful for our collaboration throughout the past years. Now the time has come to show what she has achieved in her field of research, which is regarding the treatment of PCOS. Thank you very much.
Dear committee members, dear audience, it's a great pleasure today to present you my PhD thesis, which is about the role of dietary fibers and diet composition in management of metabolic disorders. My name is Anna Evelin Juhász, and as a dietitian, my vision is to improve the metabolic health and long-term quality of life of patients by promoting an effective, evidence-based nutritional strategies. And my mission is to raise the physician awareness of the scientific results regarding the role of dietary fibers and the overall diet composition in improving metabolic outcomes. In order to achieve my vision and mission, in the past 4 years, we worked on 2 studies, which are listed here. Before going to forward details, I would like to briefly show you how the dietitians work. This model illustrates the nutrition care process model, and it shows that how we use and how we integrate to a professional knowledge and how we use it in every day in a clinical practice. Evidence-based practice is essential to ensure that every patient must receive the most relevant, up-to-date nutrition care. And with my research, I aim to contribute to this. My first project title is The Galactomannans are the most effective soluble dietary fibers in type 2 diabetes. This is a systematic review and network meta-analysis. A short background of the topic. Nearly 600 million adults are living with diabetes, and 90% of the cases are type 2 diabetes, and this number is still increasing. The primary indicator of type 2 diabetes is insulin resistance, a condition in which the body cannot effectively respond to insulin. And fortunately, in many cases, it can be prevented or managed by if we avoiding key risk factors like unhealthy diet and physical inactivity. So what is the solution? Developing an effective and accessible strategy for the prevention and the management as well. And why do we need to do this? Because the current guidelines highlight the importance of the medical nutrition therapy, but they do not specify which of the dietary fibers should be used. Based on that, previous studies show that they have beneficial effects in the diabetes. But what are these dietary fibers? Fiber means carbohydrate polymers with 3 or more monomeric units, which are neither digested or absorbed in the human small intestine. Traditionally, they are classified as soluble and non-soluble dietary fibers. In this picture, you can see a plant cell, and as you can see, the different starches are locating in different places, like the resistant starch are locating in the middle of the cell, and the others, like the pectin, beta-glucan, and galactomannan, are locating in the cell wall. And they have different effects on the human body. For example, they can stimulate the gastric juice, they can resist the digestion and absorption, and they can regulate the gut microbiome. Our research framework, we had a question, which dietary fiber is the most effective in the management of type 2 diabetes? To answer this question, we used the PICO framework, where the population was patients with type 2 diabetes. The intervention and comparators were the same, the soluble and non-soluble dietary fibers, and the outcomes were the glycaemic and the lipid factors. So our aim was to investigate the most effective dietary fiber supplementation in type 2 diabetes. And we hypothesized that soluble dietary fiber intake can normalize the glucose and the lipid levels in patients with type 2 diabetes. We did a systematic search in 2021 on 3 databases, and at the end of the selection process, we could include 56 eligible articles. Due to the time limitation, I'm only presenting you my main outcome results in detail, and the others will be in a summary table. The first one is the network interventions regarding to hemoglobin A1c level. The size of the notes is proportional to the number of the studies evaluating each type of intervention, and the thickness of the edges is proportional to the number of each direct comparisons. The second graph is the Sucre curves. The surface under the cumulative ranking curve is a numeric presentation of the overall ranking and present a single number associated with each type of treatment. The sucra values are ranged from 0 to 100%, and higher the sucra value and closer to 100%, higher the likelihood that therapy is in the top or one of the top ranks. The last one is the rankogram, which represent actually the sucra percentages. And as you can see, at this outcome, the Galactomannan was the most beneficial one. So the hemoglobin 1 in the hemoglobin 1c level. And we had more significant results when we compared the Galactomannan with the no fiber. This is the summary table, what I mentioned. Here you can see on the left side the different types of dietary fibers, what we included. And we had 9 outcomes, and I highlighted with red the most effective dietary fibers in each outcome. We did a quality assessment. For the risk of bias assessment, we used the ARROW-B2 tool. And about the results, we got low from high risk bias, and for the certainty of evidence, we made the grade assessment, and most of the outcomes had low certainty of evidence. As a conclusion, I can say that the Galactomannan was the most beneficial intervention for 4 outcomes from the 9. These were the hemoglobin 1c level, the fasting blood glucose level, the triglyceride level, and the LDL cholesterol levels, and it had more significant result. Our study strengthened that, as we know, it was the first network meta-analysis in this topic. We used a rigorous methodology. We could include 16 types of dietary fibers, and almost 3,000 patients' data were used. Of course, we have limitations, the small number of the direct comparisons, the different doses and formulations of the dietary fibers, and the patients had various background diets, medications, and lifestyle. As a summary, I can say that the dietary fiber supplementation is a good way to increase the daily intake of dietary fibers, especially in managing type 2 diabetes. But to get more evidence-based data, we need more further long-term high-quality RCTs, in which, for example, the researchers should use other types of dietary fibers in other types of disease. Our second project title is ranking the dietary interventions by their effectiveness in the management of polycystic ovary syndrome. This is also a systematic review and network meta-analysis. The global prevalence of polycystic ovarian syndrome is around 9.2%, is actually based on the diagnosis, but the diagnosis is usually based on the Rotterdam criteria, which requires at least of the followings: the ovulatory dysfunction, the hyperandrogenism, and the polycystic ovary morphology. But for these women, usually they have more clinical manifestations like insulin resistance, hyperinsulinemia, and obesity as well. And according to the literature, these manifestations can be cured or managed by a specific dietary components, so that's why it's needed to formulate for them an evidence-based nutritional strategy in the management of PCOS. Because the latest current guideline states that there is no evidence to support any of type of diet composition overall the outcomes, which are the anthropometric, metabolic, hormonal, and other parameters. So that's why new evidence needs to be assessed. We had a clinical question: which dietary approach has the highest effect on normalizing metabolic and hormonal measures in women with PCOS? To answer, again, we used the PICO framework, where the population was women with PCOS. The interventions and comparators were the different types of dietary intervention, and we included the gold standard medication, which is the metformin, and the outcomes were the anthropometric, the metabolic, and the hormonal measures. So we aim to identify the most effective dietary intervention in treatment of PCOS, and we hypothesize that these dietary approaches can normalize the metabolic and hormonal parameters in women with PCOS. So we did a systematic search in 2022 on 5 databases, and at the end of the selection process, we could include 23 eligible articles. Again, I'm only just showing you our summary table of the results. In this article, we had 10 outcomes, And on the left side, again, you can see the different types of dietary interventions, and I highlighted with red the most effective one for each outcomes. We also did a quality assessment for this article, and I can say that basically the results were the same as in the previous one. So the risk of bias was from low to high risk, and the certainty of evidence in most of the cases were low. And as a conclusion, I can say that the DASH diet was the most beneficial intervention for 4 outcomes, again from the 10. These outcomes were the HOMA index, the fasting blood glucose level, the fasting insulin, and the triglyceride levels, and it had more significant results when we compare to the patient's normal or basic diet. And our study strengthened that, to our knowledge, again, this is the first network meta-analysis in this field. We use the rigorous methodology, and most of the relevant parameters in a PCOS are included in this study. And of course, we have limitations, the small number of the direct comparisons. In the articles, the low number of the patient, and these patients had various age and ethnicity. So as a summary, our data provides a basis for dietary intervention recommendation for women with PCOS, and other main conclusion from our results that reducing the daily amount of calorie and changing the quality of the food is much, much better than those diets when they change the ratio of the macronutrients, like low-fat diet or high protein diet, for example. But to get more evidence-based data, we need to assess more RCTs with a longer follow-up time. During my PhD studies, I had many additional activities in the past 4 years. I had more poster and oral presentation at conferences. I started to working at the Department of Dietetics and Nutrition Sciences. I started to working with the Hungarian Dietetic Association. And I would like to sincere my thanks many people who helped me to stand this stage where I'm standing now. First of all, I would like to thank to Professor Péter Hegyi, who believed in me at the very first point at the admission interview and let me start my PhD studies. Secondly, to my supervisor, Réka Hermanné Juhász. She was always there for me. She attended every group meeting with me and supported me. And also thanks for the other CTM workers, Brigitta Tajcs and Szilárd Vancsa, who helped a lot for me. And also for Professor Nándor, who always helped us if we had any questions. And a huge thank to my colleagues who let me make my PhD studies and gave my dedicated time. And my deepest thanks to my family, who was standing by me patiently, even during the challenging times. And let me end with Hippocrates' quote, "Let food be thy medicine, and medicine by thy food." Thank you for your kind attention.
Thank you very much for a clear presentation. So we go to the opposition and the discussion. So the first opponent, Professor Sima.
I really congratulate you for your presentation and for your work. I also read your thesis and it was impressive. I have just 2 cumulative questions in single one, because I think it's better. So you said something about the regional impact of the diet. You found on the meta-analysis that most of the studies were from Iran, and I didn't see an impact of that in the results. So was nothing important about this diet comparative with the Mediterranean diet, which was in one study, and you said it has an impact on the results. Can you explain that, please? How we can see the difference? The Iran were in 15% of the studies, yes, and the Mediterranean diet was in one study with an impact.
Yeah, thank you for your question. Actually, it's absolutely has an effect on our results because the different nationalities don't use any types of diets. So maybe that can be a good answer for this one. For example, from Iran, they didn't use the Mediterranean diet. But if they would use, maybe we could get more better results from that area. It's not so popular there. What I can say for that, actually.
Yeah. Okay, then we go to the second opponent, Dr. Farkas.
Congratulations. One quick question. What mechanistic pathways do you consider most responsible for the Galactomannan and DASH diet superiority in case of type 2 diabetes and PCOS? And my second question is, do you have any data on gestational induced diabetes and the Galactomannan correlation?
For your first question, my answer is that the main effect is the slowing the absorption and digestion, actually. And with a lower postprandial glucose level, they will have a lower insulin level as well. So that's why it could work. And the answer for your second question, I haven't seen any data to use these dietary fibers in gestational diabetes, but it could be a good solution for them as well. I think maybe in the future we should consider to assess this topic.
You're satisfied? Other question or no? Okay. Then we move to the experts. Dr. Martin.
Thank you very much for the presentation. Your first study addressing the effects on diabetes. My question relates to the limitations of the study. How do we know that these are true, genuine results and not something related to lifestyle issues? Is there any way that you can screen and filter your results for these factors, please?
During the selection process, we try to focus on and include just those RCTs when the patients got dietary fibers, and for example, when they had any other intervention, like any other supplements or physical activity, we excluded those articles. So maybe that can cause better results for us. But to be honest, the interventional studies always have a high risk of bias, actually, because a lot of things can affect these parameters.
Thank you.
Thank you. This is a speedy defense, very good. So the second expert, Dr. Balogh.
Congratulations on your presentation. I think you choose the hardest way to evaluate the different diets and the supplements, because it's, I don't know, in endometriosis especially, it's very hard to give recommendations to the patients and any other things. So I was wondering, do you have any recommendations regarding the doses of the fibers? Did you check this in the first study?
In the first study, the dosages were very, very different, actually. From the Galactomannan, the patients got only 1 grams per day, for example. And from the psyllium, for example, they got 10 grams per day. So these were very different, actually. But they have different mechanism on the human, so maybe... But they have different, but it's basically the same. So maybe it can be good for them.
Yeah, it's hard to answer this. And what do you think? Are you able to create a recommendation for women with PCOS based on your data, mainly on the second one, because you showed the evidences are low?
Yeah. Not a high certainty of evidence recommendation, but we should consider it, especially, for example, about the DASH diet. We should consider about the high intake of fruits and vegetables and their ingredients like the antioxidants, magnesium, potassium. So I think these elements should be considered and recommended for the patients, not especially DASH diet, what they have to use or should use.
I think so. Yeah, thank you very much.
Okay, Professor Varga.
I mean, first of all, I try to ask question which is not related to statistics, although we will see. Second, that maybe this will slow down the whole process anyway. So can we go to your first diagram, which have the columns? This Galactomannan, I mean, that's so much better than the others.
Yeah.
What is the mechanism of action? This is the crazy question. How because, I mean, many of these do physical things in the intestine, most probably. I mean, they bind certain things, slow down the movement of it, and so on. But this might be something additional, because there are some components which you don't think in advance that is happening, but maybe that release is actually something which may go to the bloodstream, or it may induce some bacterial shift or whatever. So is there any idea? Because this is really very striking.
Yeah, actually the Galactomannan can be fermented by the bacteria, and if the bacteria can ferment, they can produce the shorty chain fatty acids, which has, for example, effect on reducing the lipid factors as well, or the circulating glucose in the blood. For example, that can be one answer for this one. And the next one is that in that article where they used it, the patient had to take it before the breakfast with 1 glass of water, for example. And I think that, but just my thoughts, after that they felt fullness and they ate much less than they wanted actually. So maybe that can be the solution.
Yeah. Did they measure BMI kind of things in those studies? I mean, how it changed? Or
maybe they did, but in this study we didn't include those outcomes, just the glycaemic and the lipid factors.
Anyway, this is very striking, and I think this is really worth to go after, even here, doing studies like that. I don't know if you are in a position.
Yeah, we are planning, absolutely. Yeah.
Very good. Okay, good luck with those.
Thank you.
Other question is your second study table. What is normal? I mean, we have a Hungarian normal, a Romanian normal, Dutch normal, even different parts of Hungary or in different districts. So what is normal?
Yeah, actually...
I mean, because this could be a big problem, actually, when you compare different studies or bring them together.
Yeah, when we selected the full text, we had a focus on these diets, and we were considered that what should we use, normal or basic diet, because now I know that for everyone is different, but the researchers collected the diaries, 3-day diary from the patients, and based on that data, usually the energy intake, and based on the macronutrient ratios, we said that okay, it can be the normal, which is basically the same as in Hungary. I know for the nationalities it's absolutely different, but the energy intake is basically the same, what we can say here in Hungary, normal diet.
Yeah, so I think actually this label is perfect. So I was wondering, because you have quite a few outcomes, how many of your papers assess like basically all of them, or so were there some papers that only assess 1 or 2, or how good is like the coverage, I guess?
Yes, as you can see in this paper, for example, when they use the low protein diet, they only measure the fasting insulin level, for example, or the Mediterranean diet, they only measure the BMI. So not all of them used every outcomes actually.
And can you comment on how does that affect kind of your ability to compare them if you look at this table? So because, for example, the DASH diet, right, that assessed all of them and then came out quite good in a lot of them, but then some of them assessed quite a few of them. Yeah. So what are your thoughts on this challenge?
Actually, this Bayesian method, what we used, take care of this weight actually, and we have a possible ranking of the different dietary interventions, and if we didn't have a direct comparison between some of them, with this method we could measure an indirect comparison, and these are comparable with each other, even if they had only 1 outcome or from the 9 or the 10 outcomes.
Yeah, so in general, because I think you showed like the network plot in the first one, but not the second one.
I haven't showed the network plot because I have 10 networks plot for this study and 9 for the previous one. So I just, because of the time limitation, I only made.
But you showed one, right?
Yeah.
And that was like kind of star-shaped.
Yeah.
So that means, right, that there are many studies that compare like one fiber to another.
Yeah.
It's only like fiber versus no fiber.
Yeah, there weren't any articles when they compared with each other 2 types of dietary fibers. So that's why this method could be a good solution to estimate an indirect comparison between them.
Yeah, right, but it also means that every time basically that in these studies you compare 2 fibers to each other, it's always indirect.
Yeah, absolutely.
And then of course, because there are certain like methodological differences between the papers, like maybe one of them takes it before breakfast and the other one like, you know, has a different dosage or such.
Yeah, that's why I mentioned the certainty of evidence unfortunately low. In these interventional studies, I think that's how it works actually.
In terms of kind of the future, what do you think would be the solution to that?
If I would start this study again, I would measure, for example, subgroups and more analysis on the different types of fibers. Maybe we should check which is fermentable, or can use the bacteria, or which has just can slow the absorption or the digestion. So maybe with that we would get more specific data in the type 2 diabetes.
Okay, thank you. So great for being so concise, both the questions and the answers. It allows me to discuss with you. I'm a practicing clinician, but also a researcher. PCOS has been a great interest to us for many, many, many years. There has been a lot also from a clinical perspective about a diet and basically trying to reduce body weight. There are many studies from a gynecological perspective, just trying to reduce body weight. The biggest problem in those studies has been dropouts. That many of those women did not fulfill whatever, the 3 or 6 months, because it was more than 50% were the dropout rates. So my first question to you would be, is there any link between the type of diet and dropout rates?
Actually, we haven't measured this, how difficult to keep these diets for them, but the dropouts was very high also in those articles what we included, and the start of the number of the patients at the starting point was even low actually. Yeah. Like for example in the first study the articles included 90 or 100 patients, but in these studies the PCOS women were only around 30 in the 2 arms.
But then would you agree with me that it might be useful from a clinical perspective to maybe go for a diet which may be a little less effective in terms of improving surrogate outcomes, but if people are exposed to it for a longer period of time, at the end of the day for later life that may be more beneficial. Is that stretching it too far?
It can be a good solution, but I think if more dietitians could work with this patient and support them and have a consultation every week, for example, to try to keep this diet, that would be much, much better, I think.
Very good, very good. I like your answer, and I fully agree with you. You know, these clinicians, you know, they look so superficial. They say they only look at BMI. So I fully agree. Another point that I would like to bring is, of course, here you're looking at basically surrogate outcomes. You look at biomarkers, whatever, fasting insulin or other markers. Of course, at the end of the day, the only thing that really matters is how it affects real-life endpoints. And I understand it's not been the core of your focus, but you must have been reading around this. So if these biomarkers improve with whatever diet, how does it affect the clinical parameters? At PCOS, usually these women present with either cycle abnormalities or infertility. Is there any link between improvement in biomarkers and those clinical features for which patients actually visit a doctor?
So you mean by that, what is the direct effect between the outcomes and the dietary interventions?
Yeah, direct effect, but also in terms of diet, you know, if you would tell a patient that a given diet is preferred because it improves a given biomarker, yeah, that doesn't mean much for a patient. You know, she has a problem, and the problem is either bleeding or fertility. So it would be much more convincing if you say, if you follow this diet, your clinical outcomes will improve.
Yeah, absolutely. And in a long term, so those patients who want to, for example, be pregnant in a short period, these interventions not the best solution for them because we need to use medications and so on. So for those patients who has, for example, menstrual irregularities or acne and they are young, for example, 20 years old, maybe we can convince them to keep this diet because I think it's more suitable and they don't have to take medications at the first point.
Congrats on your nice presentation. My question is there now a recommended dosage of fibers, soluble or insoluble, for these diabetic patients for daily intake?
The overall dietary fiber intake should be 30 or 40 grams per day, especially for everyone, actually, not just for patients who have type 2 diabetes, but over 50 grams, it's not recommended. They can have some symptoms like bloating, feeling fullness, so the maximum is 40 grams. And with the foods, it's sometimes hard to reach this amount, so maybe that's why the dietary supplementation could be a good solution to increase this fiber intake with 5 or 10 grams per day, for example.
Thank you very much.
Thank you so much.
Let me just, congratulations, fantastic presentation. I was overwhelmed. Just continuing Gabor's question on normal. What is normal? What is healthy? Because I just can't get my head around this. What is healthy food? I think it's...
It's different for everyone, actually.
Ah, that's it. Personalized medicine. That's it. You should have said, it depends, right?
It depends, yeah.
Excellent. Okay. My question is answered. Thank you.
Thank you so much.
Any follow-up questions? Okay. Then thank you very much. And then we are going to withdraw as a committee. Thank you.
Thank you.
Mrs. Evelin, I hope you enjoyed the presentation and the discussions. You too are officially now can be considered a PhD that is granted and at a 97% level. So my sincere congratulations. Very well done. Great job. Good study.